Hello. Today we will discuss pancreatic cancer. The main learning objectives are as follow: to appreciate the function of pancreas and associated tumors, and to review the clinical presentation and management of pancreatic tumors. The outline of the lecture is as follows. First, we will review the classifications, including endocrine versus exocrine pancreatic cancer, the prognosis, followed by symptoms and clinical signs, risk factors and pathophysiology, initial investigations and diagnosis, and finally treatment and management options. Moving on to the epidemiology and prognosis of pancreatic cancer. Prognosis is poor. As for all stages of pancreatic cancer, there is a 5-year survival rate of 6%. Globally, pancreatic cancer is the 8th and 9th leading cause of cancer mortality for men and women, respectively. Pancreatic cancer is classified based on 2 types of tumor. The majority is comprised of exocrine tumor, while the rest is comprised of endocrine tumor. Most of presentation today will focus on exocrine tumor, while the final slide will be on the different types of endocrine tumor. Exocrine pancreatic tumors come in various forms. The most common is the pancreatic ductal adenocarcinoma. Colloid carcinoma is a subtype of pancreatic ductal carcinoma with the best prognosis. Actinoma cell cancer of pancreas and pancreatoblastoma are other forms of exocrine pancreatic tumor. The common symptoms presented in exocrine pancreatic cancer includes the following. Symptoms include fatigue, generalized discomfort, anorexia, loss of weight, jaundice with or without dark urine, nausea and vomiting, and it may also present with abdominal or epigastric pain. Common clinical signs include jaundice, right upper quadrant mass suggestive of hepatomegaly, cachexia, and less commonly is associated with ascites or Kosovar sign, which is identified by palpable but not tender gallbladder at the right costal margin. Because 60 to 70% of all exocrine pancreatic cancer are located in the head of the pancreas, while most of the remaining tumors are in the body or tail, this supports the notion that the majority of the patients presents with painless obstructive jaundice. Some less common presentations including new onset of diabetes, Trousseau syndrome, or superficial thrombophlebitis due to hypercoagulable state of the pancreatic adenocarcinoma. Risk factors are divided into environmental risk factors and hereditary risk factors. Environmental risk factors include cigarette smoking, obesity and sedentary lifestyle, a Western diet with high intake of saturated fat, processed meat, but this is controversial. Hereditary risk factors include hereditary risk association with first-degree relatives, BRCA1 and BRCA2 gene, and Peutz-Jeghers syndrome. Since patients with pancreatic cancer often present with nonspecific symptoms and signs initially, patients will present with any signs suggestive of pancreatic cancer, such as painless jaundice or epigastric pain, need to be evaluated initially with lab studies. And these include hepatobiliary markers such as AST, ALT, ALP, and bilirubin, pancreatic markers such as lipase and CA19-9. Images are the next level options depending on the patient's symptoms. For evidence suggestive of obstructive jaundice, ultrasound is great for detecting obstructions or large masses, but are less useful for identifying smaller masses. Other options for detecting choledocholithiasis include ERCP or MRCP for further workup on any unidentified obstruction. For patients with epigastric pain or weight loss, abdominal CT can be conducted to further identify any masses. Abdominal CT could also be used to confirm masses suspected from a positive initial ultrasound. Biopsy may not be needed to histologically confirm the pancreatic cancer, especially if the imaging completed has already suggested typical findings. And a quick word on tumor markers. CA19-9 has a sensitivity around 70 to 92% and a specificity of 68 to 92% depending on the tumor size. It is typically used to monitor tumor response to treatment, but not to diagnose pancreatic cancer. Moving on to treatment and management options. The only potential cure is surgery, but surgical treatment is only an option for about 15 to 20% of pancreatic cancer patients. Resectability depends on the vascular, such as SMA involvement and extrapancreatic invasions. Vascular invasion could be assessed by triple phase, contrast-enhanced helical CT. Options for resectable cancer include adjuvant chemotherapy and/or radiation therapy. However, there are no standard guidelines on chemo or radiation therapy and is mainly provider dependent. For unresectable cancer, radiation therapy alone, chemotherapy alone, or chemoradiotherapy could be an option, in addition to supportive management. Here's some examples of the endocrine pancreatic cancers. Gastrinoma is a tumor that overproduces gastrin and is associated with multiple endocrine neoplasia, or MEN, type 1. Glucagonoma overproduces glucagon and is often found in the body or tail of a pancreas. Insulinoma overproduces insulin and is associated with hypoglycemia and is the most common neuroendocrine pancreatic cancer. Somatostatinoma overproduces somatostatin, and a quick review that there are 3 parts of the islet cells, which include insulin, glucagon, and somatostatin. Finally, there's VIPoma, and this is associated with WDHA syndrome, or watery diarrhea, hypokalemic achlorhydria. So in summary, there are 2 main categories of pancreatic cancers: exocrine versus endocrine cancer. And the other key take-home message is that overall, there's very poor prognosis for exocrine pancreatic cancers, and they make up the majority of pancreatic tumors. Here are some of the key references for this presentation, and thank you very much for your attention.